All right, thank you for joining us. I hope you can hear me, and we'll just go ahead and get started. I'm gonna share my screen if that's okay. Okay, and I will send out these notes at the end of the hour. So we basically are still in the middle of the surge. I think I showed you the CalCat site yesterday, and we can actually go there today if everybody wants. It's something that I look at very frequently these days, sometimes hourly, just because it's so interesting to see how things are going. I looked at it this morning, and as you can see, there's some areas of the state that are experiencing a relatively declining R effective, which is the transmissibility. So here you see the Bay Area is now under 1, which is good. You want to be under 1 because that means that your outbreak is eventually going to peter out. However, San Joaquin Valley is still above 1, and that's kind of where we fall. So while some parts of the state are just a hair under 1, others are just right at or above 1. And so we're still, unfortunately, going to have an increase in numbers rather than a decrease. Statewide, this is what the forecast looks like. Remember, the dashed line here is where we are today, and these are the different models. Some are optimistic and some are pessimistic, but really things are going to continue to get worse, and hopefully by early to mid-September start leveling off. ICUs may not level off until later in September. When we go to our county, this is what I like about this modeling program, is they basically got it to where you can dial in county by county. So that's really when people ask us, how are we doing? How's our county doing? I actually go to this website. This is where we get our modeling. And what this shows is today we're at 310 daily hospitalizations with 56 ICU beds. And unfortunately, that number is going to go up to almost 600 in just a couple of weeks if things keep going the way that they're going. Again, there's optimistic and pessimistic models here. Unfortunately, the pessimistic model has been right. So when I showed you this model before at the end of July, again, they had optimistic and pessimistic models. The pessimistic model is what came to pass between July and now. So just to let you know, this is basically where you can look at the numbers if you're interested in doing the surge modeling. They don't really drill it down to hospital level, but countywide, this is where we are. Fatalities we are already starting to see a rise in fatalities, which is really sad. I consider these preventable deaths, and it's related to vaccinations, and that rise will continue. So that's kind of where things are. There's also something called scenarios, which again kind of carves up these numbers according to these scenarios, and again, this is for the whole state, where things seem to be leveling out statewide, again, because some regions have an R naught that's less than 1. For Fresno County itself, again, we've got a couple more weeks of pain, and then hopefully things will start to level out and hopefully start to decline into the fall months. So all of this segues well into what I wanted to talk about, just going back to this other document. Sorry, let me share again. Which is about surge planning and something called load leveling. So a load leveling order is now in effect, and this really affects hospitals, although it may affect all of us on this call, and it affects the whole region. And basically, this is to help hospitals deal with surge and some of the capacity constraints that they're all experiencing. As you can imagine, they're experiencing challenges related to staffing, to be sure, spacing and where to put patients. Supplies, as far as I know, are doing okay, although I'd love to hear from people on the call about how things are going with supplies. And the load leveling order, there's probably a better name for it, but that's kind of how we're referring to it, is a statewide policy that has to do with patient transfers and making sure that all hospitals are in communication with each other and with the county and with the Mohawk system and the EMS system to make sure we know exactly how well we're using these resources as a region and as a county. And then this is not officially part of the load leveling order, but our EMS system has also switched to what's known as the assess and refer policy, to where not every single call will automatically get transported to a hospital. If it's something that can or should wait and get transported elsewhere, like a primary care center or an urgent care center, then they're sensitive to that. And that's just, again, done to help try to decompress the hospitals during this extremely busy time. Okay, so hopefully if you are working at the level of the hospitals, none of that is news to you. And I know that there's a lot of dialogue that's already happening. And I just want to say thank you. I know that this is a very challenging time at all of our acute care facilities, our congregate living facilities, our skilled nursing facilities. And I just want to say thank you for the hard work that you're doing and trying to really just hunker down and survive this phase and do the best that we can by our patients. And again, in terms of best practices, obviously vaccinations, I'm not going to spend a whole lot of time on vaccinations today. I really want to talk about monoclonals because I really feel like this is still being relatively underutilized. And monoclonals, remember, can be given not only for treatment of COVID, but even post-exposure prophylaxis. And they're so easy to do now, you don't actually even have to do an infusion. You could do a subcutaneous injection and just do a brief period of observation and then send that patient back out the door. There's mobile units that are doing these around the country. There's urgent cares that are doing them here in Fresno County. I'd love to see more skilled nursing facilities and hospitals start to do this so that we can offer this to our patients. This is, again, another way to go upstream. This is another way to save beds in your hospital, in your nursing home facility that, you know, if patients are at higher risk because they're a close contact and they meet these criteria, or if they already have COVID and they're in their very early days of COVID, then they really should be considered for monoclonals. The one that's being used most commonly now is called Regeneron. So we have a whole policy on how to do that and which clinics are offering it. Dr. Zweifler has worked really hard along with some of our other staff physicians at the health department to help make this up to date. So for those of you that are doing it, thank you. For those of you who are not doing it, I want to shame you into really considering this because it's something that you really need to know about. Sooner or later, your own patients are going to ask about it. If you end up getting staff that fall sick, you're going to want to know about this to try to protect them as much as possible. And we really need more of this being done. It's not a supply issue. There's plenty of supply. It's really just an issue of creating the procedures and the processes to make this happen. And now that you can do it subcutaneously, it just seems like a no-brainer. So I know that I'm probably painting with too broad of a brush, but it's really something we all need to know about. I'm going to send you, again, all of these notes and also a link to our monoclonal policy statement at the health department. And I just found these are notes that the state sent to us. So I just kind of copy pasted them in here about who qualifies, who doesn't qualify, and how to give them. Okay, vaccines. There's been some news about vaccines, as you have probably heard. Last week, we heard that supplemental doses or third doses for immunocompromised patients are now approved. We approved those right away in the county, and basically the state followed very quickly over the weekend and said that this is okay to do now. Immunocompromised, again, it's a pretty broad term. They're keeping it broad. They're allowing patients to attest that they do have an immunocompromising condition or that they're on immunocompromising medications. But in following up that attestation, they should be totally ready to show documentation and show proof that they actually need it, because we don't want people to abuse the system. And these immunocompromised patients are now good to go if it's been more than 28 days after their last RNA dose of Pfizer or Moderna. Okay, so that's part one. Part two is now people are talking about boosters. This is less well worked out. Basically, what the White House has said is that on or around September 20, they're going to greenlight boosters for anyone that got an mRNA vaccine. Okay, that's really all the White House has said. We haven't heard it from the CDC. We haven't heard it from the FDA. The reason that the White House said this is because they basically are saying that they anticipate that the FDA will approve during the week of September 20. And as soon as that these are FDA approved, then a booster shot will be supported. It's controversial. Not everybody understands why it was done to begin with, first of all, because it seems like vaccinated patients aren't really the ones that we're having problems with. And second of all, there's kind of this other ethical issue of why are we giving vaccines to Americans when the rest of the world hasn't even gotten their first dose? And that's really what's going to come bite us if the rest of the world doesn't get vaccinated, then that's where these variants are going to come from. There's a lot of other equity issues just related to the fact that, if vaccinations save lives, we should really be trying to broaden that instead of just boosting people that are already well protected. Anyway, more to come between now and September 20th. That's not live yet. You're probably getting inquiries from patients to say, hey, I need my booster. I'm not immunocompromised. And what you can tell them is to say, why don't you hold on until September 20th? Because that's when most probably we will have all agencies in alignment about how to proceed. The reason that they chose September 20th, it seems to be the 8-month mark for the majority of people that got their first round, the early adopters. And for whatever reason, the 8-month mark is a time when antibody levels may fall. Again, I haven't really seen the data that supports that too much. I think it's coming from other countries like Israel, but that's kind of where people are getting the 8-month duration for boosters. Okay, so those are supplemental doses for mRNA patients. Boosters to come in September for mRNA patients. What do we do for Johnson & Johnson patients? They're being told to hold on and wait. To me, this is becoming, it's going from a level of irritation to negligence, in my opinion, because these patients really do still have the same risks. And it could be argued that, if anyone is going to have a failure of vaccination, it's going to be the Johnson & Johnson patients. And that's just, again, based on literature that reflects that vaccine is not as protective as the mRNA vaccines. But be that as it may, the FDA and the CDC still do not want Johnson & Johnson patients to, be approved for supplemental doses, and they're just being told to wait. I get the feeling it's going to be just in the next few days to weeks that we hear something about Johnson & Johnson. But if you go try to look up a policy today, right now, to help justify why we should give these folks extra doses, you're not going to find anything written on paper from any official authorities. And that's related to the Johnson & Johnson vaccine. Again, this is less than 20% of the overall vaccinated population has gotten Johnson & Johnson. I think the last statistic that I read was that it was around 13% nationwide. But we know that, 13% is still a lot of people when you multiply that by, 180 million people that have gotten the vaccine at this point. So we know that there's millions and millions of Johnson & Johnson patients, including many of them here in the county of Fresno. We haven't forgotten about them. We're still just asking them to hold on because we don't want to be redundant or contradictory to something that the state or the federal authorities put out regarding J&J vaccines. The other question that we've gotten, and this is an interesting one, is what do you do about adverse effects or adverse reactions or side effects? Well, the vast majority of them are pretty self-limited. They last less than a day, and they can be taken care of with just some basic over-the-counter first aid like antipyretics, anti-inflammatories, and that's kind of the recommendation. But what if you have somebody that's got a more serious adverse effect, like the very rare case of myocarditis or blood clotting, et cetera, that seems to happen in very rare cases? Well, that's where the National Vaccine Registry helps a lot. And there's actually a national vaccine program that helps to cover these patients for their medical bills, et cetera, et cetera. I would say work with your HR and really even your legal counsel about this. if you're dealing with an employee or if you're helping a patient that has these super severe side effects, because they are eligible for compensation. The specific question that we've had was workers' compensation, and I don't know. I mean, it really depends on what your workers' compensation policy actually says. So again, work with your HR and your legal counsel. Just keep in mind that there is kind of like a federal program to help compensate patients and families that have serious adverse effects from vaccines. And it may take a little bit of digging, but certainly reach out to us if you need help finding how to access that program. And when I send out these notes, I'll try to find a link that might point you in the right direction. So that was another question that we got this last week. All right, so moving on to staffing help. A lot of folks are very short on staff, as you can imagine, just related to isolation and quarantine and other really just policies and dynamics related to the healthcare systems right now. The state has sent out a very helpful list of staffing agencies, and they really want this shared broadly. You can actually contact these folks yourself if you need help. Just start dialing or emailing them. And these vendors have worked well with deployment on short-term or longer-term contracts, and the state recommends them. They've been vetted by the state, as you can see, and the state says that they have a high standard of responsiveness, speed, and clinical competency. So just for those of you who are looking for staffing help, reach out to these agencies, and hopefully that will help with some of your staffing needs. And I just wanted to put that in there, just because I know that that's a need. Let's talk about exemptions. So there's two types of exemptions that we're fielding questions about. Vaccine exemptions for vaccine mandates, and then masking exemptions, especially related to schools. So with vaccine exemptions, again, the state officer order that's out there for healthcare workers says that a healthcare worker can request an exemption related to a medical issue or a strongly held religious belief. So with the medical exemption to the vaccines, people are asking us, well, what is the list of items that would qualify for a medical exemption to the vaccine? And in all of their wisdom, the state didn't really create a list or provide a list. And from what we can tell, these are the contraindications. So this would be the medical contraindication that would allow somebody to get exempted from a vaccine. There's only like two that I could find. One is an allergy or Guillain-Barré syndrome from having received the mRNA vaccine. So again, these allergies and even the Guillain-Barré syndrome does not cross-react with other vaccines. So if you've had an allergy to the flu shot or an allergy to a tetanus dose, that doesn't necessarily disqualify you or exempt you from getting the mRNA vaccines that are being used, or just the COVID vaccine itself. With the Johnson & Johnson product, that's an adenovirus vaccine. There's other adenovirus vaccines that, if somebody had an allergic reaction to those, then that would actually count as an excuse to not get the Johnson & Johnson. But, there's no reason why somebody that's allergic to the adenovirus vaccine cannot get, there's no reason why they couldn't get the mRNA vaccine. So hopefully that's clear that, there's just a very limited number of people that should actually be medically exempt from getting vaccinated with the mRNA vaccines. There's also the concept of postponement. So if someone's pregnant or expecting to be pregnant or breastfeeding, then they can actually postpone for a period of time, at which time they would then need to go ahead and get their vaccine. And then really it's up to them and their physician to kind of tailor a plan to make sure that it makes sense. And obviously it's in the best interest of a pregnant woman to get the COVID vaccine, because that's very protective throughout the pregnancy. And it's actually recommended, highly recommended, that pregnant women get the COVID vaccine. But it's understood that they may have some reservations. And so they do allow for a postponement related to pregnancy, breastfeeding, et cetera. Then there's also a postponement that's allowed for if you've had the monoclonal antibody, then you can actually wait up to 90 days to get your COVID vaccine, because it's thought that those antibodies would probably be protective during that time. If you've had COVID, you can wait up to 2 weeks. And then basically after 2 weeks, you're good to go. You can wait longer. And I think up to 90 days is okay with that too. But post-COVID, it's understood that you can actually get a postponement for that as well. But you should still go ahead and get your vaccine. So just because somebody's had COVID that's not really a get out of a vaccine card. They still have to go ahead and get a vaccine, although they can postpone for a short amount of time after they're recovered from their infection. So hopefully that makes sense. If there's other conditions that you have questions about, or if you see something or read something that can add to this list, please let us know. We're having to create this list, like I said, locally, because the state's not providing one that I can find. And I can't even find anything on the CDC website that talks about, what is a list of conditions that would qualify for medical exemption. So I'm just taking the list of contraindications and using those as the list for medical exemption. With masking, it's a little bit more straightforward, and there's actually really good statements that have been put out. First, kudos to Dr. Dahl, Dr. Birnbaum, Dr. Gady, Dr. Reutman, and everyone else at Fresno Madera Medical Society, Stacy Woods, for putting out an amazing statement. That's the second bullet point here. And this is really a statement that says, if you are going to have these conversations with parents, then read this statement first, because this basically will put you in a really good position to have these somewhat hard conversations. It's not just about masking exemptions, but obviously masking exemptions are covered there, and they did an amazing job. In fact, this was circulated by the Fresno Madera Medical Society, and then very quickly picked up all around the state. And then soon afterwards, the Board of California actually put out their own statement that was in alignment with, although had a slightly different emphasis, and that is that first bullet point here. And this statement from the Medical Board of California actually says that, as you can read, inappropriate mask exemptions might subject physicians to discipline. So if you are going to do these, do them the right way, because you can expect to be scrutinized by the Medical Board of California. And in fact, that could be one of the talking points from pushy parents, is to say, hey, look, my license is on the line and I have to do this the right way. And if you don't agree with me, I'm so sorry, but you can actually just tell people that. So hopefully that will give you a little bit more confidence in having these conversations. I know it's hard. I know that people are really pushing you to do to do exemptions for both vaccines and masks, but just keep in mind that, we don't want these systems to be abused. And that's why these statements are out there. I urge you all to look at them, to know what they say, and not be pressured or intimidated. And obviously we will totally have your back if you need us to intercede or intervene. So let us know. A flu order is coming, so we're actually getting ready for flu season already. I know it's only August, but really October is when flu season starts to really kick into gear. And it's anyone's guess how things will go with the surge and the wildfire and the air quality. There's a lot of reasons for our respiratory patients to get super sick related to the flu, and for the general public to also have issues related to influenza this year. So we are going to do our flu order. It is going to be very similar to what we did last year for healthcare workers. If you're interested in looking at a draft, I'm happy to circulate that. But look for that. What I'll do is I'll plan to go into a deep dive with that next week. And so just keep that in mind that we are working on it. It's going to have the same contours and much of the same language as it did last year. And if you want to look at a draft, then you can look at last year's draft, which should be posted online. Or we can send you a draft of this one if you want to just get an early peek at what it requires. And then the one of the last points that I want to make is actually something not related to COVID or flu, and it's about fentanyl and opioids. So as you know, this is another interest of mine. Fentanyl has actually gotten renewed interest because of a video that was circulated last week or the week before about law enforcement officers in San Diego. And one of the officers gave the other one naloxone because they thought that they were overdosing. And that has gotten wide circulation. It kind of got turned into a viral video. And we've actually had a lot of law enforcement requesting naloxone from our hospital, probably as a result of watching that video. I think what people need to know is that, although there are volleys that are being sent back and forth about, I guess, the veracity of that video, the fact of the matter is fentanyl is still out there. It's still deadly. And our first responders, whether they work in law enforcement, the pre-hospital paramedic setting, or in the emergency department are at risk. And we want people to know that, to be aware of it, not to be paralyzed by it, not to be panicked about it, but just to be aware so that we can educate ourselves and educate our patients that this is actually a very deadly opioid. And unfortunately, it is circulating out there. So in the interest of just building something constructive from this episode, I just want to give you the talking points so that you have them as well. And in case you ever have these conversations with your patients, relatives, or community. It is deadly. Fentanyl is very deadly. It kills a lot of people, especially when they intentionally overdose or accidentally overdose trying to get high. And usually it's due to oral exposure, meaning pills that contain fentanyl, or inhalational, meaning they actually smoke fentanyl either in combination with other opioids or in combination with methamphetamines. Dermal exposure is very low risk. And so this is, I think, the biggest point of consternation is whenever toxicologists see people just touching fentanyl powder or even looking at fentanyl powder, and then they think that that's going to kill them. That's not how it works. Otherwise, people wouldn't be doing it IV. Our drug users would just be putting it on like sunscreen if you could get fentanyl high from doing dermal exposure. That's not how fentanyl works. You actually have to work really hard to get it into your body, meaning that you have to swallow it or inhale it or use a needle to get that into your body. The skin is actually a good barrier against fentanyl exposure. So I think people need to know that because they think that dermal exposure immediately translates into a deadly overdose. Panic reactions can occur, they do occur. It's good that our community is alert related to fentanyl, but it's bad whenever that alertness turns into panic and even syncopal episodes. Remember that even if somebody passes out, obviously they do need medical attention and they may need an EKG and other things like that. But if they don't have apnea, they don't need Narcan. So again, naloxone should only be used if the patient's not breathing, and naloxone is available and free from the state. So this is where, I really want to urge all of you, you should be applying for this naloxone grant that the state has available. If you have a clinic, if you have an urgent care center, if you have a skilled nursing facility, definitely if you're working in the hospital or the emergency department, just have naloxone handy. You never know when you need to give it to someone who's at risk. Just the fact that we have it in the emergency department, we're able to just give it to so many people, from law enforcement all the way to people that are actually using drugs or know people who do. This is just speaking to a huge demand in our community, and we really need more distribution sites. Public health is about to get their own distribution site going so that we'll be able to start handing it out from public health department, but we need other health departments, other state and local agencies to start doing this as well. So please partner with us. The application is super easy. It takes 5 minutes. The state will send you free naloxone. It's a very expensive drug if patients try to go buy it at the pharmacy. And then lastly, don't forget to get your X waiver. That's how we're actually going to solve the opioid epidemic. We're not going to arrest our way out of this. We're not going to Narcan our way out of this. Suboxone and buprenorphine are the best hope that we have for putting the opioid epidemic behind us. So basically, what vaccines do to COVID, buprenorphine does to opioids. We really need everyone to be on board and get this into people as soon as possible, because that's how we're going to move forward and get beyond the pandemic of opioids that's going on at the same time that the pandemic of COVID is going on. And I can tell you more about that. Just contact me offline. I could talk to you for hours about the opioid epidemic and all the things that can be done. There's actually a lot of good news related to that, which is why I like to talk about it. But that's basically what's going on. Finally, you might look outdoors and just see that our air quality is terrible today. The AQI is actually 152. Anytime the AQI is greater than 150, the letter of the law says that outdoor workers need to be wearing N95 respirators. So actually, in addition to the N95s that we're all wearing inside the emergency department, you're actually supposed to be wearing an N95 outdoors if you're a field worker outdoors. We know that this is probably not being done except in a very small minority of patients, but that's actually the letter of the law. And so you should just know that that's how bad the air quality has gotten right now, is that it's bad enough to where OSHA wants people to be wearing N95s out there. So it's not just you, we're all feeling it. Hang in there. Hopefully this bad air will pass through, but we know that more is to come, that climate health effects are just now starting to be seen, and they're going to get worse before they get better. And that's why we've created the C6 Coalition. That stands for Central California Climate Change Clinical Collaboration. We'd love to have your help. So reach out to us and help us build this coalition to look at healthcare impacts and healthcare resources related to climate change, which I really do feel is the next pandemic. Even when we get through, and we will get through COVID, we will still have climate change to deal with. And we really need to just get really smart, because as you can see, these pandemics have the power to disrupt so many things in healthcare delivery and in the rest of our lives. Those are all the notes I have for today. Thank you for joining today and putting up with this draft form. I'll finalize this and I'll add more links and I'll share these out with everyone. And I think in the meantime, we have enough time for Q&A or other comments and observations that people have. And I'll just try to go through the chat. Sorry, I didn't get to do that last time. But if you want to speak up, just unmute yourselves and feel free to speak up. Okay, question. Is there any indication that there will be reimbursement for the sub-Q monoclonals in the future? I might defer that one to Dr. Zweifler if he's on, because he's done more work on this than anyone else that I know of. I know that they are free because all COVID treatments are free. I think what you're asking about is reimbursement for staff time. And from what I understand, I did get communication from our Medi-Cal contact that this would get reimbursed. And I'd be surprised if other insurance, et cetera, didn't reimburse for it. So I think that there is a reimbursement mechanism. I don't know how easy it is, unfortunately, but I bet there is if you want to start doing this, or if that is a barrier for you. And we can certainly help you track that down, especially with Medi-Cal patients. We have a really good contact, and they can actually tell you exactly how to bill and code and document to get your reimbursement for monoclonals. And Sim has shared the monoclonal antibody treatment update. We've updated this 3 or 4 times, and so please look at the latest one because that gives you the latest, all the different clinics that are now doing this, and the latest indications, including the post-exposure prophylaxis, which we learned about just a couple of weeks ago.
Yeah, it's a good question. So with the monoclonal infusions that was reimbursed.
Somebody's asking, with boosters on the horizon, what does fully vaccinated actually mean? Does it mean 2 shots or 3 shots? Right now, fully vaccinated still means 2 shots. No one's changing the definition of that. So hopefully that's clear. I know that this is a little slippery, but right now, fully vaccinated means 2 mRNA shots, and you're good. And that, if you're immunocompromised, then although you don't have a full antibody response, which is why they want you to get a 3rd dose, for everyone else, you have great immunity right after that 2nd shot, 2 weeks after that 2nd shot. Someone's asking, how long post-COVID can somebody get a deferral? So the kind of the wait period for getting a vaccine is 2 weeks. So I would say it's really up to you how much leeway you want to give people. I think if you want to give them 2 to 4 weeks after they recover from COVID to start their vaccination series, that makes sense to me. That's probably what I would do. Beyond that, I think because natural immunity is such a gamble, it's just hard to predict whether that natural infection is going to protect that employee, which is why we want them vaccinated. So if you wait longer than 4 weeks, you're really putting them at risk and giving them a false sense of security. And obviously you're putting your organization at risk if they end up being the nidus of an outbreak. I think someone's asking, for the flu mandate. Okay, so Sim shared the flu mandate letter from last week. And yes, I will put in all of the notes that I talked about today. And I'll add all these links in also. Sean's asking, if a vaccinated healthcare worker who had an exposure needs to test 3 to 5 days after exposure. If the exposure was with both masked or unmasked, does the masked versus unmasked impact the need to test? Yeah, good question. So I think you're getting into modified quarantine and what that actually means. What I would do is have them plan to test at 5 days, regardless of vaccination status and regardless of masking. The reason is because we know breakthrough infections are happening. And while those patients do okay, they may actually be transferring the virus to other people, especially other unmasked and unvaccinated people. So you really just want to identify them so they can go home and isolate. And that's why I would say err on the side of getting them tested if they had a close contact. Any guidance on what or how to accept a religious exemption? Who should actually qualify? Yeah, that's a good one too. You know, I've seen different models being proposed. Some people say, you know, you should really create a committee that's kind of a multidisciplinary committee that has medical, administrative, and religious representatives that can actually look at these exemptions and then approve or deny them in a way that's fair and as impartial as possible. To me, that seems to be the safe bet, although that logistically may be hard to do. That's what I would recommend as like the gold standard. You know, anything beyond that, if you want to have a form, you know, actually, the UC system has a really good form. It's not something that is state approved, but the UC system, and I can share that with you. I saw the one from UC Merced, and they basically have a nice long form where the person has to describe what is their religious practice, what are their religious beliefs, and really justify, you know, what strongly held religious belief precludes them from getting a vaccine. So they really have to do some self-reflection so that they understand, and then they have to sign off that, you know, they understand that by not being vaccinated, regardless of the reason, that they are putting themselves and others at higher risk, so that you have that on paper too. I think it's a good idea to create that paper trail, but really talk to your HR to see how much of this you want to take on. Like I said, I'm happy to share forms that others have used. We're not getting told that we have any requirement beyond what you've already read in the state officer order about how to make this religious exception, you know, real in the real world. So it's really up to you on how you want to do it. But I think having documentation that somebody had this conversation with the person and that a strongly held religious belief, you know, was well documented, will actually, you know, creating that paper trail will serve everyone in the long run. So I would say, you know, work on it beforehand so that you don't have to worry about it later, and you know, create a best practice that's consistent and fair. And really, you know, some of the religious leaders have great insights about this, and they're actually able to help advise you about how to talk to people. You know, clearly, I think it goes without saying, any of these loopholes have the potential to be abused. But on the other hand, there are people that have strongly held religious beliefs, and they deserve to be heard, and they deserve to have their story, you know, documented in these procedures and processes. And having a religious leader who can kind of help shepherd those conversations just seems to be a best practice. So I would say, you know, even though it does require an investment of your time and energy, it's probably worth doing. And if you have, if anybody on this call has already figured that out, then you're more than welcome to speak up and let us know how that's working. Current Medi-Cal rules reimburse for administration of the IV monoclonal, but not the subcutaneous. It's a big barrier. I don't know about that. I could double check. I think the reason for that is probably because the infusion came first and Medi-Cal just had more time to figure this out. I bet it's just a matter of time before they say, oh, you know what? We forgot to add in subcutaneous now that that's available. It's just the subcutaneous is literally weeks old. So I can see how the government bureaucracy hasn't caught up with adding that to the reimbursement tables and things like that. But we can certainly ask. Good question. Thanks, Grace. Fully vaccinated people exposed, or if they have symptoms, they get tested, but they need to quarantine too. Yes. So if they have symptoms, for sure they do. If they're exposed and asymptomatic, and they test negative, then I don't see that they need to quarantine out of work. They can do something called, we call it a modified quarantine on the school side. I think it's called directly supervised quarantine or something like that on the work side. But either way, it means that they can't continue to work as long as they're asymptomatic and they test negative on day 5. All right, Lance says we could really help more people if the FDA would step up the full authorization. True, totally agree. I think it's going to happen in the next month. Lots of reasons have less merit than I don't want to take something that isn't fully approved. True, very true, Lance. Thank you. On the other hand, if it's approved too quickly, then people will say, oh, it was approved too quickly, and now I don't believe the FDA, they've lost their credibility. So I think the FDA has to walk that fine line also, because I don't know, we just live in a time when, you know, just because you have scientific expertise doesn't mean you have the influence and credibility, and that's a real sad reflection. That's a real sad reflection on our society, unfortunately. But that's kind of where we are. Is, you know, even the smartest people are having a lot of trouble just, you know, trying to get their voices heard because there's so much misinformation out there. All right, I think I've gone through all of the chat questions, but happy to hear from you if you have any more. We learn a lot from these sessions, so I really appreciate you all spending your lunch hour with us and teaching us what you're hearing and what you're concerned about. All right. Hi, Rick. I think, you know, Rick has popped on. That reminds me that with these boosters coming along, we've also fielded questions about mass vaccination clinics and whether we're going to be doing them. And really, obviously, the state has also fielded those questions, because you will remember that they invested a lot of resources into mass vaccinations in the early months of the vaccination campaigns. It appears now that there's enough providers in the system to where we may not need to do like the mass vaccination clinics. Like, for example, you know, we had one set up at the fairgrounds. We actually just had a call with the big Fresno fair, and guess what? They're actually planning to have a fair this year. So they don't want to give up those buildings for mass vaccinations unless they absolutely have to. So, you know, what we believe, and we hope that we're accurate, is that there are enough providers in the system to accommodate the demand, even with the boosters. Obviously, the demand is going up, and that's good. We wish the demand was even higher because there's so many unvaccinated and vaccine skeptical, vaccine hesitant individuals. But nonetheless, we feel like there's enough in the My Turn system to where you punch in your zip code and you get a bunch of options about where you can go to get your vaccine. You know, hopefully we'll have more clinics coming online as they can. Hopefully we'll start to vaccinate people, you know, in innovative ways, like through schools, through employers, through hospitals at the time of discharge, even through emergency departments. That's the hope, is that we just reach people where they already are, instead of trying to attract them to a mass vaccination site where the logistical difficulties just add up very quickly. We really should just be setting up like in the malls and the stores and the events, and just meeting people where they are and just giving them their shots there. That's easier said than done, but that's the hope, is that that's the way that we can go with these boosters and supplemental doses. The supplemental doses for immunocompromised people, it's only 2% of the population. You know, it's a very small number of people that will actually qualify based on immunocompromising condition. And so they're not really thought to, that's not what's going to overwhelm the system. If there's a run on the boosters for every single person that wants a third dose, wants it on the same day, like on September 20th, then that's actually going to strain the system. And obviously the My Turn system is supposed to handle that, and it's supposed to you know, schedule people when things are available, and not schedule people when things are not available. And so because that system is now built, it's felt that mass vaccination sites are not going to be required. But having said that, if you want to do one, we're certainly going to support you. If you want to set one up for healthcare workers, for example, if you want to set one up for different occupations that are more at higher risk, like first responders, law enforcement, et cetera, we would love to see that happen. Please talk to us if you're interested in doing that. It's a great way for you to serve the community. If you have bandwidth in your operations, I know everyone's busy, but if you feel like this is like an easy thing for you to set up and do, we would love to hear from you, and we'll support you with our VAX planning team. So Kelly says, I wish we could use doses that we're going to waste as third doses. That's a great point, Kelly. What I've said is if you're going to throw away a dose, you can go ahead and use it as a third dose. Just make sure that that person meets criteria, meaning that it's been approximately 8 months since their last mRNA vaccine. And I know that 8 months seems like a long time, but remember, we really started rolling this out in January. And so as soon as September hits, that's not a problem that you're going to have. You're going to have a ton of people that will qualify based on that 8-month criteria. So again, I hate to see doses wasted too. So I would say, I think that there is some leeway where if you have to choose between, throwing a dose away and giving somebody a third dose, then I would say choose to give them a third dose and just make sure that that's done appropriately. And that's been our, we've always had that on the books, is never waste a dose. And so this is very consistent with what we've said all along, is don't let doses go to waste.
I so wish that other
and then Lupe's asking, do we know if the COVID vaccine standing order needs to be updated by the provider for the third dose? Yeah, that's a good question. I think it depends on which standing order you have. So we do have a countywide standing order for our mass vaccination clinics, and really for some of the Optum Serve sites that are doing vaccinations. And that's something that I signed. But if you have a local, or not a local, but an organizational order that one of your medical directors has signed, just look it over. If it says something that makes you think that a third dose is not covered, then basically you may have to revisit that. I haven't seen the CDC order it looks like it was just from July. So I don't know, the CDC doesn't actually write orders. They actually just make recommendations. So you have to keep that in mind as well, is that's not an actual order. The orders have to come from either the state or the local Department of Health, or you can do an organizational order from a physician on your site or in your organization. So I would say, whatever the CDC says, treat that as a strong recommendation. Obviously, what they say, carries a lot of weight, but legally it's not an order. Is it 8 months from the first or the second dose? It's 8 months from the second dose. It's 8 months from the second dose. And then someone's asking, Pfizer had a separate booster in the works. What is the plan? So the third dose is basically the same as the second dose. And that applies for the immunocompromised individuals. And from my understanding, that will also apply at the September 20th third dose booster approval. It will basically be the same as the second dose. It will be the exact same dose, exact same volume, exact same concentration in the third dose. All right. Any other questions or comments? This is a great discussion. Okay, well, we will get these notes finalized, add in all these links. Just give us a few hours. I'll try to get this pushed out by later today. And I really appreciate your patience. I know this is changing quickly, and I know that everyone is very busy. Just let us know how we can support you. Hang in there, take care of yourselves, and have a great rest of the week. All right. Lance, yeah, no more. I mean, you're going to hear about lockdowns when we do. It's basically, but we're not anticipating any more restrictions from the state. They did put out an order related to massive mega events indoors. So basically, if you are crazy enough to go to a concert indoors somewhere, they want you to verify your vaccination, and it has to be more than the honor system. You actually have to bring your card. But that's for indoor mega events. That was the only kind of big order that the state put out for the general public recently. beyond that, they really want local orders. And I can tell you that locally, we're going to continue to strongly recommend masks, and that's about as much as we're going to be able to do here locally. Until something else changes, you'll probably know as soon as we do. And yes, you're right. It's vaccinated or proof of negative tests for, looks like Colleen's already getting ready to go some concerts. So yes, you're going to be fine. Vaccinated or proof of negative tests. The big Fresno Fair is going to put on a cool, it's going to put on, thank you. It's going to put on a really good set of concerts, but they're all outdoors. So we talked to them, and there's going to be a lot of good bands coming through outdoors in October. So hopefully the surge will be behind us then, and we can all enjoy some great live music here in Fresno. Thank you all. Take care. Bye.